Good afternoon and welcome. I know we have a few more people coming, but we have a full agenda for a really important topic today, so we want to get started on time. So welcome again to the Wilson Center. I'm Roger Mark D'Souza, and together with my colleague Sarah Barnes, Sarah, who many of you know, we direct the Maternal Health Initiative here at the center. And we're able to do this with a lot of support with partners like you, but in particular, we work quite closely with the Maternal Health Task Force at Harvard University. So we have our colleagues Jackie and Kayla here, thank you, and our colleagues at UNFPA. Geeta Lal is here with us. Where's Geeta? So Geeta's here. So thank you very much for that support, collaboration, and engagement. Many of you know at the center, we focus on doing policy-relevant research, convening dialogues such as this one, and strategic communications to get these key messages out. And we could not take advantage of the fact that we have an opportunity to celebrate the 30th anniversary of the Safe Motherhood Initiative. This is such a critical initiative for us. It offers us an opportunity to not just look back, but also to look forward and see what's on the horizon and to be able to motivate others and show what's possible. So it's in that spirit that we're able to celebrate the 30th anniversary today. We have two really engaging panels, and our first panel is going to be moderated by Petra Tenhoop Bender, who is the Technical Advisor for Sexual and Reproductive Health and Rights at the UNFPA Office of Geneva. She's a midwife, yay! Former Secretary General of the International Confederation of Midwives, former Executive Officer of the Partnership for Maternal, Newborn and Child Health, and Director of the Dual Career and Staff Mobility Program at the United Nations. She's quite busy. She's coordinated the Lancet series on midwifery in 2014 and was the lead author of the international policy paper of this series. She's also co-authored the State of the World's Midwifery Reports for 2011 and 2014, and she has expertise in policy development, implementation and analysis, operational support to countries, organizational development, workforce assessment, advocacy, and communications and capacity building. Wow. So Petra, welcome, and I hand it over to you. We're delighted to have you here.
Thank you very much.
Thank you.
Thank you very much. It's a great pleasure for me to be here, and I'm very honored as the first, my first interaction with the Wilson Center to also have the opportunity to pay a very short tribute to Dr. Babatunde. He was a UNFPA Executive Director from January 2011 until he died in June of this year. And from the time he became a doctor, he was dedicated to serving people, especially women and girls and youth. He was known to be bold and never afraid of a challenge, and his strong leadership really helped keep the health and rights of the world's women and girls high on the global agenda. He understood that the world's 1.8 billion young people are truly its asset for the future. He vigorously championed three transformative goals: 0 preventable maternal deaths, 0 unmet need for family planning, and the elimination of harmful practices against women and girls, core to UNFPA's mandate. Before he was appointed, he was Nigeria's Minister of Health, and before that he was Director General of the National Agency for the Control of AIDS, and he coordinated HIV and AIDS work in Nigeria. He qualified as a doctor from the University of Ibadan, Nigeria in '72 and went to the University of Birmingham, England, where he got a doctorate in medicine in '79. He was appointed professor at the University of Ibadan in 1980 and then headed the Department of Clinical Pathology before being elected provost of the College of Medicine in 1990. So you see he's had a very long-standing career in our area. He received the Nigerian National Honor of Officer of the Order of the Niger in December 2005. UNFPA has pledged to continue to carry the torch that he's passed on to all of us by standing up for human rights and dignity for everyone, particularly the most vulnerable adolescent girls, and to advance the ICPD agenda, especially in these challenging times. Thank you. So in continuation and furthering the work that Dr. Babatunde has done and that UNFPA, together with all the colleagues in the room, carry so dear and close to our heart, I have the great honor to bring before you a panel of friends. Our first speaker today is Barbara Quast. She brings with her over 50 years of professional experience as a specialist in maternal and child health and midwifery education, and as an epidemiologist focused on implementation, monitoring, evaluation, morbidity, and in addition to diplomas in nursing and midwifery education and family planning and tropical medicine, she has a master's degree and a doctorate in epidemiology. She's worked in Malawi, in Nigeria, in Ethiopia, which is the country that's very close to her heart, where she's done a lot of work with the Hamlin College of Midwives. And she has been crucial and a core collaborator to the global Safe Motherhood Initiative and movement, and as a member of the technical support team to UNFPA to assist with the formulation of maternal, newborn, child and family planning country programs. So she's very experienced in the things that and you feel that and hear that in what she's going to be telling us later today. She also worked with the US Agency for International Development's Mother Care Project, which was one of the first ones, 1992 to 95. So it's really lovely to have all that history in the room. Barbara, the floor is yours.
Thank you very much for this introduction, Petra. Good afternoon, distinguished ladies and gentlemen. I would like to thank the organizers for the invitation to participate in this special event. What a joy to gather with so many people here today, all with their interest, knowledge, and expertise supporting the Safe Motherhood Initiative. This is worth a celebration. The genesis of Safe Motherhood was a birth process in itself. Precursors were the Alma Ata Primary Healthcare Declaration in '78, the UN Decade for Women, and the first ever WHO interregional meeting on the prevention of maternal mortality. The initiative was hosted by the government of Kenya in Nairobi and supported by WHO, the World Bank, UNDP, UNFPA, and other donors at the time when unsafe motherhood was a monumental challenge. In 1987, 500,000, I've said this already, so I'm sorry about this. In 1987, 500,000 women died due to pregnancy and childbirth. When you have looked into the desperate eyes of a mother dying from a ruptured uterus who asks you, "Am I going to live?" When you have looked into the panic-stricken eyes of a woman dying on the labor ward floor from an unpredicted torrential hemorrhage, when you have looked into the anxious eyes of an adolescent girl dying from unsafe septic abortion she had procured by selling her gold chain to an ambulance driver, then behind these numbers are faces that remain forever carved in your heart and memory. Professor Mahmoud Fatala, who also stood at the cradle of the Safe Motherhood, presented us the reasons and barriers on the road to death of Mrs. X, the perilous way of a poor pregnant woman to her delivery, which was at the same time the end of her life. Let us all reflect whether the barriers Mrs. X faced have all been opened, whether they are still open, whether they have been partially closed again, or were never opened for the most vulnerable poor women and their families. A call to action in Nairobi addressed the barriers on the road to death of Mrs. X. Among others, the three-pronged approach of health sector strategies included strengthening of first referral level facilities to provide life-saving essential obstetric functions as close to the people as possible. 8 essential obstetric functions at first referral level were presented in Nairobi and subsequently included in Safe Motherhood programs. They addressed the major causes of maternal mortality and included neonatal special care and family planning. Requirements for blood banks and essential drugs and equipment were also included, and attention was paid to housing of health workers, particularly in rural areas. Management of labor with the pantograph at all levels of maternity care for the prevention of prolonged labor, postpartum hemorrhage, sepsis, and maternal morbidity and perinatal mortality was included. You see here the application of the pantograph for more than 40 years being passed on from the older generation of midwives to the younger generation. This is Malawi. These midwives and health workers all over the world are today struggling with the realities on the ground, and we want to celebrate their contribution to the safe motherhood as well. Our social responsibility obliges us to emphasize labor and delivery in the continuum of care, not only for the reduction of maternal and perinatal mortality, but also the debilitating morbidity of obstetric fistula. Millions of women's lives are in shreds due to glaring inequity, social injustice, and inadequate healthcare systems. Safe motherhood is a work in progress. Selected landmarks in the last 30 years are mentioned in this slide. Safe Motherhood at 10 in Colombo showed lessons learned and challenges in reaching the goal of 50% maternal mortality reduction in 2000. Therefore, 1998 was designated by the World Health Assembly as the year of safe motherhood. Pregnancy is special. Let us make it safe. Paradigm shifts took place from selection of women at high risk to all women are at risk, needing emergency obstetric care when complications arise. From essential obstetric functions to emergency obstetric functions. And these were divided into basic emergency obstetric and neonatal care at health center level and comprehensive emergency obstetric care at the hospital level. Management of labor of first or second stage with a pantograph was not included. Another paradigm shift was from TBA, traditional birth attendant, to skilled birth attendant training. Professional midwifery could save 3 million lives if enough midwives were in place to treat complications and if enough and adequate facilities were accessible to treat complications. More than half maternal deaths in stillbirth and neonatal death could be averted during moments of greatest risk, 48 hours around the time of delivery. Millennium Goal number 5 meant an intensified push for institutional deliveries. To relieve the crisis in intrapartum management and improve the quality and respectful childbirth care, many visible, like you see here, overcrowding and lack of privacy, and invisible issues could be addressed. The Patuma project in Zanzibar is showing us that appropriate training with locally developed guidelines for labor management can significantly reduce stillbirth and birth asphyxia. The unfinished agenda of the Millennium Goal number 4 and 5 is still the tragic loss of so many women and their babies every day today. The greatest challenge for the future of safe motherhood and SDG 3 are the human rights agenda, political will, empowerment of women, and peace. And for all of us, perseverance. It always seems impossible until it is done. Thank you.
was a really wonderful start of this conference and this session. And the thing I really wanted to ask you, we'll go into a larger debate, but I'll ask one or two questions of the speakers after their presentation. And it's going to be the same question for all of you. So what has this meant for you as a woman and for the things that you've experienced? How has it impacted your life? And what has it helped you do or become? How does it keep you going?
Thank you very much for that question. I think 20 years in Africa, in Malawi, Nigeria, and Ethiopia, have shown me so many maternal deaths and so many fistula patients. It remains a social injustice. Women shouldn't die giving birth. Women are not pregnant 9 months to have a stillbirth at the end. And I think that motivated me. Yeah, and still today, when I go to Ethiopia or Zanzibar, for that matter, 3 years ago, to train, to educate midwives, doctors. There is such an enormous need. People want to be taught. They are hungry for knowledge. And it is a two-way. It is a dialogue. It is invigorating when I go there. It is going home. It is coming home. And to be able to participate will be something for the rest of my life.
Wonderful. Thank you so much. Okay, on to our next speaker. My good friend Anne Stars. I feel really lucky here today because it's like working with family. She assumed leadership of the Guttmacher Institute in August 2014 and became the 5th president and chief executive in the 46 years since the organization's founding. She's widely recognized as an expert in reproductive and maternal health and has authored and co-authored numerous papers and commentaries on global health issues. During her nearly 30 years in the field, I'm not going to tell you a lot more because she has some introductory slides herself, so let me give her the floor.
Thank you, Petra. Thanks to all of you for coming, and thanks for the opportunity to think back over it. It has been, in fact, more than 30 years. So it's great to be able to be here with you. I'm going to speak wearing two hats. I'm going to start out with some of the history. You'll see up here some shots from various key documents along the history of the Safe Motherhood Initiative, including the Preventing the Tragedy of Maternal Deaths, which was the report on the first Safe Motherhood Conference in Nairobi in 1987. And I think I've been working on that issue. I was working at the time for Family Care International, which was a new organization, which was the secretariat for the Safe Motherhood Initiative from 1987 until 2004, 2005, when the Partnership for Maternal, Newborn, and Child Health was established. Many of you know, of course, the incredible figure Jill Sheffield, who founded Family Care International, which then organized, and few people remember this, actually the first Women Deliver Conference was organized by Family Care International. It was a project or an initiative of FCI, and then Jill went on to, she stepped down from her role at FCI and went on to lead Women Deliver. So I have seen a tremendous evolution in the issue of maternal health, in the language that we use to talk about maternal health. And we'll be talking about that a little bit. The bulk of my presentation, which I'll get to in a minute, is putting on my Guttmacher hat. But before I do that, I wanted to make 3 observations about maternal health, building on Barbara's comments and Barbara's presentation, looking at the evolution of safe motherhood, maternal health, primarily from a political perspective. I think my first point is that when we look at the issue of maternal health now, it's striking how mainstream, how integrated the issue of maternal health now is. Barbara mentioned the Where is the M in MCH Lancet piece written by Deborah Main, Alan Rosenfield, 2 other crucial foundational figures for the movement, and that was a valid question. Maternal health really was an invisible issue in the mid-1980s. I know it's kind of shocking maybe for those of you who are newer to this field to think about that, but it's true. It really wasn't very visible that 95% of the focus of what was called maternal and child health was really focused on child health interventions. Whereas now we have an integrated effort to sexual, reproductive, maternal, newborn, child, adolescent health, the SRM and CAH, that's our new acronym, which I refer to as the SNEEZE. But we also have the inclusion. We obviously had MDG 5 in the year 2000, which was a crucial point for the maternal health issue in terms of visibility and political attention. We have now, of course, the inclusion of the maternal mortality target in the Sustainable Development Goals, target 3.1 to be specific, so that shows the prioritization. And we have maternal health, skilled birth attendant, maternal mortality and skilled birth attendant as key indicators for the SDGs for universal health coverage. So I think it's really important to acknowledge and to recognize that maternal health is very firmly on the agenda. It may not have as much the standalone visibility as it did at some points during that history, but I think the fact that it is fully integrated is a critical achievement. The second point, and it's semi-related, is around the political prioritization that maternal health and maternal mortality has achieved, that it is identified by heads of state, by ministers, by celebrities, by heads of agencies as a crucial goal that they are obliged and obligated to pursue, to talk about, and to try and address. And then my third point, and again, this builds on a comment that Barbara made, is when the Safe Motherhood Initiative was first launched, we struggled with some of the messaging. Should we talk about the importance of women to economic development and what is the economic cost of maternal mortality? But I think, and while that is certainly still a very valid point, we really have shifted. If you think about the rationale that is used these days to focus on maternal mortality, it's very much around maternal mortality as an issue of human rights, of equity, and of social justice. And I think that messaging frame is really what resonates for all of us, certainly for me, what was to anticipate your question, Petra, it's what resonated with me from the beginning. Okay, so now I'm taking off my Family Care International Safe Motherhood Initiative Secretariat hat, and I'm going to put on my Guttmacher hat. And what I'm going to share with you is some findings from a study that some of you may be familiar with. It's a series of reports and studies that the Guttmacher Institute has been producing since 2004 called Adding It Up, looking at the costs and benefits of investing in reproductive health. So Adding It Up presents a comprehensive estimate of the needs, impact, and cost of both contraceptive services to prevent unintended pregnancy, as well as maternal and newborn care. So the numbers I'm going to present here are from the developing world, so it's spanning 140 countries in Asia, Africa, Latin America. So here are the key messages from the study. There are 214 million women in developing countries who have an unmet need for contraception. And probably all of you know what that means. These are women who say they don't want to become pregnant but are not using a modern method of contraception. Meeting this unmet need would result in a 75% decline in unintended pregnancies, unplanned births, and induced abortions. Only 1 in 3 of the women experiencing complications during pregnancy and childbirth receive the care that they need. So again, highlighting Barbara's point about we still have a long way to go. Providing full contraceptive and maternal and newborn care would reduce the annual number of maternal deaths from 308,000 to 84,000 and would reduce the number of newborn deaths annually from 2.7 million to about 540,000. All of this is cost effective, that providing these contraceptive and maternal newborn health services would cost about $8.50 per person per region. So I'm going to run through some numbers quickly. This slide shows that in 2017, there were 1.6 billion women of reproductive age. More than half of them, 885 million, so that green number on the right, want to avoid pregnancy. Of that 885 million, there are 214 million women who have this unmet need for modern methods of contraception. They're either not using any method at all, that's 155 million, or they're using a traditional method, which often have questionable effectiveness. Note that this 214 million women with an unmet need for contraception is a decline from the most recent figure, most recent estimate that was issued in 2014 when it was 225 million. So we are making progress in terms of access to and use of contraception. So what are the consequences of this unmet need for contraception? It's what you see here. 84% of unintended pregnancies occur among women who have an unmet need for contraception, who are either not using any method at all or are using a traditional method. Of course, there is some portion of unintended pregnancies that do happen to women who are using contraception because, as we know, method failure happens. There are important and significant disparities across regions and across countries by income level in terms of the proportion of contraceptive needs that are met. If we look at met need, that's what's shown in this graph, for example, the proportion of women who do want to avoid pregnancy but are using modern methods of contraception is lowest in the lowest income countries at 49% over that right-hand set of columns, and is highest, 86%, in upper middle income countries. We also see, again, large gaps that persist across regions in the receipt and use of essential maternal health services. Again, by region, which is the way it's shown here, that Africa has the lowest rates of pregnant women who receive at least 4 antenatal visits and have the lowest percentage of women who deliver in a health facility. This slide shows what the impact would be if we fulfilled the need for modern contraceptive services. What would happen? The number of unintended pregnancies would decline from 89 million to 22 million. That's a 75% decline. The number of unplanned births would go from 30 million to 7 million. And the number of induced abortions, many of which are unsafe, would go from 48 million to 12 million per year. This chart, I'm just going to have you look at the first column, which is the 308,000 maternal deaths that happen every year now. And the two parts of this graph show the number of maternal deaths that are due to unintended pregnancies, which is the top part, and then the number of maternal deaths that are due to intended pregnancies. So that first chart shows you the current numbers. The last chart, the last bar on the right, shows you that decline in maternal mortality that could be achieved by addressing the unmet need for both contraception and maternity care. The message here being that both are critically important. Okay, this slide is slightly complicated, so I'm going to walk you through it. It shows essentially the cost benefits of investing in particular in contraceptive care. The first column shows you what the current spending is for contraceptive and maternal and newborn health services. The second column shows you what would happen if you had 100% coverage of maternal and newborn care, but didn't invest anything more in contraception. So the total price tag then to address all the unmet need would be 60 million. The third column shows you how much you save, in essence, by providing contraceptive services. The total cost goes down because by preventing unintended pregnancies, the amount that needs to be spent for maternity care declines. Next to last slide, don't worry. So, key point, investing in both contraceptive and maternal and newborn health saves money. This slide shows you that basically $1 invested in family planning saves $2.20 on maternal and newborn care. So just the last point, and again, all of you will know this, what do we need to do? We still need greater investments in maternal and newborn care and contraceptive services. All sources of funding need to invest in those. There's a much greater focus these days on the importance of domestic funding. I haven't presented data on this, but we all know this, that the return on investment is far greater than just the health benefits, that there are lifelong benefits to ensuring both access to contraception and maternal and newborn care. Thank you very much.
Thank you very much, Anne, and indeed a very complimentary presentation to Barbara's, and really kind of showing us ways forward, which, not that we didn't know them, but just seeing how enormously successful they can be and the impact they can have is really good to start us off on the discussions today. So you answered my question already slightly. I'm going to put it back to you in a little bit more of a personal way, because there has been an impact on your life from starting with FCI and kind of going now to a completely different institute. And so can you talk to us a little bit about that and what keeps you going? Thanks.
Sure, happy to. My commitment, my personal engagement, my sense of mission around this work is rooted in a commitment to enabling women and girls to achieve their full potential. And I chose this particular channel, this issue, because for me, and for all of us, understanding that being able to control their fertility, to go through pregnancy and childbirth safely, was fundamental to women's lives, to enabling them to do what they could do for themselves, for their families, for their communities, and was in turn critical to the well-being of those families and communities. You know, I have worked, not to the extent that Barbara has certainly, but have worked and lived overseas. I remember, you know, living in Uganda and again doing outreach in communities and asking people in villages, how many of you know a woman who has died in pregnancy and childbirth? And almost everybody, this was in the late 80s, would raise their hand. And as Barbara said, and as I hinted at in my presentation, for me, I think our achievement in making maternal mortality an injustice that needs to be recognized by health ministers, by heads of state, by heads of agencies, has been, I think, you know, the single greatest achievement of the Safe Motherhood Initiative. And I'm incredibly proud to have been able to play a role in that. You know, my focus now is, as I said, on the sort of broader reproductive health agenda, and Guttmacher in particular focuses somewhat more on the issues around contraception, abortion, adolescent sexual and reproductive health, but it is all part of a continuum. They're all interrelated. So it's been, yeah, transformative for me.
Thank you, thank you. On to our last speaker for this session, and then we'll be very happy to open the floor. So Betsy McCallan is the Executive Officer of the White Ribbon Alliance. She's responsible for setting the strategic direction of the organisation and developing the plans, setting up a dynamic team, and finding the resources to deliver it. So, I mean, you know, you're like a superwoman to me. McCallan joined the White Ribbon Alliance in 2004 and has contributed to the growth of the Alliance from a loose network to a driver for global attention and commitments to maternal health and rights with a focus on national accountability and advocacy. She's currently, she's worked in 15 countries. Actually, that's at the bottom of what you described, but I think I wanted to put that up a little bit higher. She's worked in over 15 countries in sub-Saharan Africa and Central America, so really seen the realities on the ground. Currently, she's a board member and chair of the Partnership for Maternal, Newborn and Child Health, and she's passionately an advocate for citizen participation to accelerate advancement for maternal and newborn health and rights. You have the floor.
Thanks very much, Petra, and good afternoon, everyone. It really is an honor for me to be here. Thank you so much for the invitation. To be with so many leaders of the movement, mentors of mine. So it's really a pleasure. I think similarly to what others have said, I also, in preparing for this, was reflecting on what drew me to the movement, and it also was about social justice. And for me, maternal mortality was just that measurable indicator of the lack of value placed on women's lives. And as we were wrapping up the MDG era and preparing for the Sustainable Development Goals, these issues that Barbara and Anne have already touched on, of equity, of human rights, of the broader social determinants, became more prominent. In 2013, the global community started setting out a vision to end preventable maternal deaths within a generation. And in Bangkok in 2014, over 30 countries built consensus on this vision and set world global goals. WHO, USAID, others really saw a grand convergence where through concerted efforts that we could reduce the highest levels of maternal deaths worldwide to rates now observed in middle-income countries, and also where all countries can make progress. This global goal-setting work of a global average of less than 70 MMR became the basis for the SDG target on maternal mortality, as we've already heard, as part of SDG 3 on health. I think also really important, the global community recognized that setting an ambitious target wasn't good enough, but there must be a new strategy and approach to addressing maternal health if we're going to achieve that target. So in 2015, WHO published strategies for ending preventable maternal mortality with critical guiding principles and focus, which includes access to and use of clinical services, but also social, cultural, and economic determinants that are crucial to not only reaching the maternal mortality targets, but also other related goals. This event, an important marker of 30 years of safe motherhood, has also come at a really critical time for White Ribbon Alliance. We've been working this year to gather inputs from many of you and White Ribbon Alliance National Alliance members around the world to shape our strategy for the next 5 years. WRA was founded as a part of this movement in 1999. And we began with simply, yet not so simple, really trying to put the issue of maternal mortality on national and global political agendas. Then working to get specific commitments, policies, and investments in place. And in recent years, focused on holding duty bearers to account to deliver on those promises and working with communities to stand up for their rights. As a part of this ending preventable maternal mortality frame, I see a few areas of focus for this community in the next era if we're really going to accelerate progress. The first is around politics and universality. Of course, political and societal decisions have always been important to this movement. And when I first began my career in this area, we were regularly grounded by the quote by Dr. Mahmoud Fatala: "Women are not dying because of diseases we cannot treat. They are dying because societies have yet to make the decision that their lives are worth saving." This still rings true today. And I see our issues embedded in this broader call for women's rights and empowerment in every country in the world. We can't focus on the technical issues alone. We can't think that the evidence and the case for investment, however compelling, will speak for itself. We have to make stronger linkages between health, transparency, democracy and governance, and human rights. We can't be afraid to speak out, and we must support and amplify the voices of the most marginalized. We must also recognize the universality of the agenda. While it's true that 99% of maternal deaths occur in developing countries, egregious violations of rights and increasing maternal mortality is happening amongst populations here in the US, in Europe, and in every country. The last few years have seen several setbacks: a backlash against women's rights and reproductive health, a rise of autocratic governments, and troubling restrictions on civil society and the media. But this also compels action and attention from individuals and leaders to engage and stand united around the world. Political leaders must see, hear, and feel, including through the ballot box, that their constituencies will not stand for inequality and injustice. And we're seeing this in many ways. In local level politics, again around the world where women are entering the political sphere, in the Me Too and She Decides movement, and in the global financing facility where increased attention and investment is being put behind these issues. The second thing is a multi-sectoral approach. The evidence tells us unequivocally that we won't reach the health targets with health sector interventions alone. And we're seeing some really exciting examples of cross-sectoral approaches and advocacy and programs that could and should be replicated. For example, to address high rates of teenage pregnancy in Uganda, White Ribbon Alliance Uganda called on ministries of health, gender, and education to develop a costed, multi-sectoral strategy and to approve a national budget with funds to support that plan. Importantly, the plan was driven by thousands of adolescents and young people themselves, demanding accountability and improved adolescent sexual and reproductive health. In Sindh province in Pakistan, where more than half of pregnant women are malnourished, addressing anemia is a key priority of the Ministry of Health. However, resources and momentum were limited. White Ribbon Alliance in Pakistan developed an advocacy strategy with the Ministry of Health, targeting ministries of education and finance to work across sectors to fund iron and folic acid, improve nutrition counseling services, and establish policies and practice that focus on the health and nutrition of adolescent girls. It led to a 26% increase in the health budget, a mass media and peer education campaign with girl guides, and new curricula for high school, lady health worker, and medical school students. Quality, equity, and dignity. We've already heard, from other speakers that a focus on survival is not good enough. We must work for the right of all to be treated with dignity and respect. This year, White Ribbon Alliance in India asked more than 150,000 women across the country to name their #1 ask when it came to quality maternal health services. Called What Women Want, or Hamara Swathiya, Hamari Awaz, the campaign was really groundbreaking. We grouped all of the findings together to present to government officials. And 36% of women, when asked what they wanted in terms of quality, really asked for the most basic maternal health entitlements of services and supplies to be in place. 23% asked for services to be provided with dignity and respect. Specifically, no discrimination based on caste or religion, 1 bed per woman, a birth companion during delivery, and complete information and consent. And not to be ignored, 4% asked for clean and hygienic conditions, including safety from monkey and mongoose attacks. Because of this campaign, the National Health Minister and Parliament committed to looking at ways to improve feedback mechanisms in health centers, take on cases of disrespect and abuse, and integrate women into policy design. These are fundamental human rights that must be in place for everyone. Accountability. I wouldn't get out of here without talking about accountability. Much of the solution really does come down to accountability of citizens and governments knowing and upholding their rights and responsibilities. There's an important role for civil society to play in brokering relationships and solutions, building trust, systematically identifying and removing barriers. White Ribbon Alliance Nigeria has been focused on improving accountability in Niger State, where the government has asked for support in building and strengthening accountability structures. They secured high-profile support from the Vice President and Health Minister and leveraged the momentum to organize combined town halls for local government areas. They're attended by women, religious and traditional leaders, youth, community activists, along with key decision makers. And together they decided that the lack of basic medical equipment for maternal and newborn health was the issue that demanded the most urgent action. Almost immediately following the town halls, the Niger State government procured and delivered essential medical supplies and equipment to 11 priority health facilities, benefiting more than 430,000 people. When it works, change is really, really rapid. Ultimately, what we need is a paradigm shift. One in which women have the knowledge and confidence to drive and make decisions about their own health and to demand the quality services that we all deserve. This means investing in health literacy and self-care. It means shifting within the thinking within health systems where providers are recognized as the experts. It means investing in a midwifery model of care that puts women at the center. White Ribbon Alliance launched our new 5-year strategy yesterday. We're doubling down on our role in supporting a people-led movement for reproductive, maternal, and newborn health and rights that we believe is the only way to achieve the maternal mortality reduction targets and to achieve a more just and equitable world for all. Whether coming together to declare Me Too, She Decides, or Hamari Swathiya, Hamari Awaz, we're excited to grow this movement with you so that all girls and women, particularly the most marginalized, can realize the health and well-being they deserve. Thanks.
Thank you, Betsy. That was amazing. You know, kind of linking this global policy level that we all love and hate and swim in, with the reality on the ground of what really the answers and the requests of women are, which are so simple. So, again, for you, what does this mean for you? How do you marry them up? You know, what keeps you awake, but also what keeps you going?
Yeah. No, thanks. I mean, you know, as I said, and definitely the initial draw on and still remains is the social justice issue for sure. And I think what keeps me really motivated are working with leaders of this movement, whether that's at a community level, you know, or at a national level. But that's what's really inspiring to me. People who in really, really, really difficult situations are standing up for their rights. Who Barbara had perseverance there. I think it's one of the key pieces, right? Who against all odds just truly believe so passionately in the rights of girls and women, and you know are willing to take risk. You know, are willing to come at it from all kinds of different angles. So yeah, I think it's that's really continues to motivate me, and to in the global bit sometimes to think about how to remember that and why it does matter, of what, you know, decisions and how the policy environment shifts and what that means to women on the ground.
Wonderful. Thank you so much. So after 3 inspiring presentations, there's an opening for some discussion with you. If there are questions or if there are statements you want to make, you don't have to ask questions, and feel free to ask for the floor.
Thank you.
Would you state your name and where you're from?
Sure. Good afternoon, everybody. I am Dr. Joya Career-Perry. I'm with the Black Mamas Matter Alliance. I'm excited to be here. Actually, it's my first event with the White Women Alliance. So, I was struck by your comment around the events that are happening here in the United States, because that's what we're working on, and trying to tie them and uplift that although we can have a wealthy nation, you can leave communities behind. And how, although we talk about equity and social determinants, if we don't dig into the root causes of racism, classism, and gender oppression, we kind of get stuck at this conversation about social determinants. So how do you see talking about root causes to this work globally in order to unpack, you know, racism, classism, and gender oppression to improve maternal mortality?
Betsy?
Oh, sure. No, great to have you here. I'm so inspired by the work that you're doing. It's so important. I mean, obviously I don't have the answers, but I think it's about tying movements together. I think it's really interesting, like from an advocacy perspective, you need specificity to be able to really drive change, right? And be able to really be dogged about the particular, you know, change that you're pushing for, and be able to measure and demonstrate change. At the same time, all of those pieces are so linked, right? And really being able to get at those root causes. So I think a lot of it is that linking up of movements, you know, the really standing together. I think, I mean, Anne and I are part of a reproductive health CEO group of groups that mostly work internationally. And, you know, remember we had some conversations, you know, earlier in the year of what does all of this mean in a new political environment? And those were some of the discussions we were having. How can we stand up and really stand together with linked movements?
Yeah, I would totally agree with what Betsy said. I do think, because Guttmacher works, 50% of our work is domestic. So I've learned a lot about that over the last 3 years. And thought about the comparisons between the situation that we see domestically and globally. And I think that there are huge discrepancies, of course, in access to and utilization of a whole range of health services, including, and you know, again, those of you who've worked in this space for a long time know that skilled birth attendants' access to maternal care writ large is the one that has the largest discrepancy. The largest gap between the poorest and the wealthiest within countries and across countries. So I think globally and in many low-income countries, it's still seen primarily as an issue of income or geography or education. I think some of these root causes that you're talking about there's not yet, I think, a kind of a willingness to really engage. Betsy could talk about this. I think obviously it's an issue in India, in a number of countries, and we know from some of the studies, particularly about disrespectful care, that challenges that disrespectful care is often rooted in differences of ethnicity as well as education, et cetera, language, et cetera. I think that hasn't yet gotten the attention it needs to, in my view, globally. But I certainly agree, and I agree with Betsy that getting linked up movements is a crucial strategy moving forward.
Roger?
So I'm Roger Mark D'Souza here at the Wilson Center, and I'm always glad when we have one of our maternal health discussions and there's another guy in the room. So I want to talk about men and engaging men. And as you reflect on the movement, could you tell me what are some of the mistakes you have made in engaging men in this space? What has not worked and what is working? So that's my first question. My second question is about how we engage young people. We typically have a lot of very bright, motivated young people who would like to have a career in this space, and they're trying to figure out how to move forward. And I would think they may look at this event today online and they will say they want to learn from you. So it's related to my other question, but where have we made mistakes? Where do you wish you knew something now that we had done earlier that would have allowed us to progress even more quickly? What advice would you give to a young person who will look back at your careers and what you've accomplished that will help them move forward? So men and young people moving forward.
Thank you very much. Opening up to the colleagues, or
thank you for that important question. I still remember I was at a big meeting, I think it was in Washington actually, and we all remember Fred Tsai, and I was on a panel like this, and I challenged Fred Tsai at one point and said, but the men. And when we listened to this afternoon also, sometimes I'm a little nervous myself. We must continue to include men. And where we have made mistakes, if it is a mistake, we tried to do a lot in the beginning of Safe Motherhood, broadly and maybe less focused, but broadly. And I actually learned in Malawi, including men in any primary healthcare discussion is absolutely crucial. Men know that their women die, and they don't want their women to die. But sometimes we think we shouldn't ask men and we shouldn't include men, because also with traditional birth attendants, when you go to a village and you say, now could we please speak to the traditional birth attendants, they say, oh, but you go to the chief, huh? Because otherwise you can't get in anyway. And then he says, oh yes, but you know, that is women's work. You know, we don't mix with TBAs, we don't address that. I always felt men needed to be involved. And I think they give the permission for the woman to go to the hospital. They hold the money, and they have to be included in programs. And I think maybe in the beginning, we were not too good at that. But we learned, I think, from the community work that we did with mother care, there's long experience there, that including men does help. And schools, it's not only the girls who are responsible, it is also the boys who are responsible. And we do need to address the boys. And I think that is important.
thank you. Barbara, anybody?
I have a quick story about that from, again, my old days at Family Care International. when we were working in Burkina Faso with a community-based project and trying to mobilize, in fact, community support and support from local leaders. And so we got a local chief who would go to the market day and would tell all the men gathered there, it's really important that you support and pay for your wives to go for antenatal care and to deliver in a health facility. All of my wives deliver in a health facility. It's like, okay, yeah, well, we're getting part of the message there. We'll just put that one aside. A little more seriously, I think, and I'm going to be slightly provocative here, and this is not evidence-based, but I wonder whether we could have had more success if we had approached this a little bit in a less about men, we're giving you the opportunity to support us, and more about men, we're giving you an opportunity to participate in and contribute to something that can bring you great joy and pleasure in terms of the child rearing, in terms of taking care. I think too often our messaging is, we own this, we women, we own this, this is our territory, this is our turf. And we will, we'll ask you to contribute money, or we'll ask you to, pay for the transportation or something like that. But we don't open up the whole process and the whole issue of being a father, becoming a father, participating as an opportunity and as a benefit. It's something I wonder about. And obviously that's very culturally specific, but anyway, I'll just put that out there. I'm gonna let Betsy deal with the youth stuff.
Well, maybe just a couple of reflections on both. I think, as Anne said earlier, I do think there's a big difference in the engagement of men on this issue locally versus globally, because it touches the lives so much more closely. So, within White Ribbon Alliance, the leaders of the alliance at the national or district level are often men. So it is more of a mix, and I think it's because there is also quite a personal connection. Whether in Tanzania, Rose Malai, who's one of my great mentors, who heads the White Ribbon Alliance there, when addressing Parliament, asked everybody to touch their belly button. Reminded them why one has a belly button. Okay, great. We're all connected to these issues. This is everybody's business kind of thing. So I think there, some of those ties are there. But I think that actually my response is the same to both. I think it's about a little bit more of a holistic, less siloed agenda. Because I think a lot of the men that have been involved in the issue are coming at it from a medical perspective, right? There are a lot of men that are very involved as experts in terms of and doctors and whatnot, and we've got this kind of hierarchical thing going. But what we hear from young people all the time, they don't see the world in these silos. They see a much more integrated world. They're looking at issues of injustice again rather than siloed. So that's one of the learnings I think that we've had. When young people are coming to the table, they're wanting to look at and work on and see the interconnectedness of a lot of these issues. So I think that's one thing, and one of the and so giving space, and opportunities to kind of take that on, which I think goes back to my earlier point of how do we better sync up movements as well.
Then to add the final point from a health workforce perspective, because I think that's part of the story. If you see modeled in front of you a good collaboration between women and men, men and women, then it's something that's easier to pick up as, oh, actually that might be normal. The International Federation of Midwives has really focused on a young midwife leader program set up together with UNFPA and several other colleagues here in the room. And what you see is that it takes off. Among the group of professionals and in conjunction or in collaboration with other professionals, including medical doctors, obstetrician, gynecologists, nurses. And in the work that we're doing at a more policy level, talking about who is a skilled birth attendant, we've moved away also from the titles of doctor, nurse, and midwife, and looking much more at competence. So what is it that they're supposed to be able to do, so that there is a more kind of a rounded approach to who's taking care of whom and who's responsible for what. And I think those are all things that help kind of take away this silo approach to you know, you have to have, or a doctor has to have this kind of role and this kind of responsibility, and he's a man. And I think that those are really helping in making this whole area of life that is so close and core to families really open for everybody and accessible for everybody. Thank you. Any further questions from the field? From the floor? Sorry, go ahead. I'm out there already.
Thank you very much. My name is Rebecca Ost from the Center for Family and Human Rights, and I had a quick question. It seems like some of the themes that tie together this whole initiative are access and use. And when we talk about the rights-based approach and the SDGs and the MDGs, the goals are really about access in most cases, whereas we tend to think of use as something that's a matter of voluntary decision-making. So when a woman or a child dies from a preventable cause, we think there was a lack of access to competent staff or a lack of access to clean blood and things like that. But I've also seen a lot of sort of, when it comes to the unmet need issue, an equating of access and use. The idea that that 214 million number gets equated to being a lack of access. But I believe the Guttmacher Institute said about 5% of that is self-attributed lack of access. And so when we see the target from Dr. Osoda-Mahan about meeting the entire unmet need, or we see the cost-benefit estimates to doing so, I'm curious to what extent those numbers are a reflection of commodities, and services being available, or to what extent that has to do with somehow overcoming other reasons why women are choosing not to use these things, and how those estimates are put together. So. Thank you.
Okay, that one's for me. Doing a deep dive into the unmet need, particularly for contraception, is a fascinating exercise, and I think we as a community need to do a much better job of it. We do have some basic information available from DHS surveys, because the surveys do ask women who are identified. The way the unmet need is calculated is a series of questions. Do you want to avoid pregnancy for the next 2 years or stop having children? Are you using a modern method of contraception? And if not, why not? And what's fascinating when you look at the responses to those questions, it varies obviously by country, by region, but this usually the largest single category, the most common reason that women give for not using contraception is concern about side effects. These days, and this has been a real change over the past 15, 20 years, lack of knowledge, lack of supplies, or lack of, or not knowing where to get it, and unaffordability are generally less than 5% now of the reason that women are not using contraception. It's really concerns about side effects, and then there's a second category, which is broadly termed opposition. Although when we did a deep dive in one country, in Ghana, trying to look into this, what we found was that actually opposition very often comes back to this issue of concern about side effects or health effects. And then there's the perception that they're actually not at risk of getting pregnant because they're postpartum, or because their husband, partner, is away for a significant chunk of time, so they just think I'm not really at risk. So it's really relatively little. I'm not saying that it's lack of supply, that we don't need more investment in commodities. That is a hugely important factor. But when you look at why unmet need exists, why women who say they don't want to get pregnant are not using a modern method of contraception, most often it's not around this issue of access. It's an issue around quality of care, I would say.
Anybody else want to? Can I then just add a question to that, Anne? Because at the moment, we have 68 situations in the world that are classified as humanitarian. I mean, if you're looking at lack of access, and oftentimes, it's available, but just really getting it there. UNFPA is one of the main providers of contraceptives in humanitarian settings, and it is such a challenge. So is there anything about how that impacts the numbers?
Well, DHSs don't happen very often in humanitarian crisis settings, so those figures I just cited are, in fact, not reflective of that specific situation. There is, I think, there was just 2 weeks ago, I think, a meeting of the Interagency Working Group on Reproductive Health in Humanitarian and Crisis Settings, and there's a new minimum integrated service package, an agreement and that will be coming out. If it hasn't come out yet, it'll come out very soon. And I think there's a much greater recognition of the importance of access to family planning and other reproductive health services including emergency obstetric care in these crisis settings. We don't have good data, is the very short answer. And we're reaching out to try and talk to some of the groups that work in humanitarian crisis settings and try and figure out how we can get better data on what the gaps are.
Super, thank you very much. I just hear we have 20 minutes and we have at least 2 more questions. So starting in the front and then the second one in the back.
Thank you. Dr. Quast, I was delighted to hear you talk about stillbirth, because so often when we are talking about these issues, we are talking sometimes about things that are politically divisive, sometimes things that are politically energizing. We heard about, She Decides, which was sort of a campaign to rebut the Mexico City policy and the campaign for more contraception. These can be very politically galvanizing, but the stillbirth rate remains so high. And when we talk about rights, stillbirth rate is actually in negotiated treaties. Countries have an obligation, those who are states parties. And yet, it seems as though it's not reduced. Maybe you could talk more about internationally. Is it moving? Are we making progress? It seems like at 2.6 million, it's just too high. And I guess the follow-on question would be, is there any chance that Guttmacher and the White Ribbon Alliance would take this on and try to get the kind of political support for stillbirth that it deserves?
Thank you for that question. I think stillbirth has not been on the agenda originally in the Safe Motherhood launch. One of the doctors from Chad at one point said, "Dead babies don't cry." That was a very emotional statement to make. And it then started to come on the agenda. It is difficult to measure sometime because resuscitation is often not adequate, and a child is put away as a stillbirth, while in actual fact it isn't, and it could have been resuscitated. And it could have then, of course, been a neonatal death, that's true, but also not. The stillbirth issue is a complicated issue. However, it was in the Universal Declaration of Human Rights in 1948, stillbirth was mentioned. And I am personally concerned that stillbirth is not an indicator in the SDGs. So I don't know what the global community is going to do about this, but there are millions who have no life at the end of a pregnancy of 9 months. And that is, of course, we're talking about against human rights, a social injustice. A woman doesn't want to be pregnant 9 months to have nothing at the end. I don't know whether I'm answering your question. Probably you are provoking me, and yeah, I have nothing to lose. I can say it. We need to measure it. Because otherwise, because the stillbirth, of course, doesn't come into the under 5s mortality. That's the other thing. We have learned we can't get under 5s mortality reduced until and unless we reduce neonatal mortality. And then, of course, the first day mortality. But that does not include the stillbirth, because they are nowhere. Does that answer your question?
It does. I did not know that it wasn't included.
But maybe I can jump in. It wasn't included in terms of the SDG targets, but there is, I think, really a growing community around this, and I completely agree it had been hidden and neglected, but that is changing. And so we have successfully advocated for the stillbirth indicator to be included as a part of the global strategy for women, children, and adolescent health, or every woman, every child. So while it's not in the SDGs, that's the kind of global framework that sits under the SDGs for the SNEEZ agenda. So it's there, and that was that from a and that's really important. And then in terms of how that looks as well, in terms of organizations and things taking it on, it is something that we're talking a lot about. And how does it link with that agenda around quality, equity, and dignity, and respectful maternity care agenda, not only from the perspective of prevention, but also as it relates to the stigma, bereavement care for women and families and providers. So I do think that is starting to get more attention, but as others, how are we also not ensuring that doesn't become a siloed agenda? So we've been trying to also bring that in, and happy to talk more with you about it.
Just to add to that there is also very much more a people's movement around this. There are many associations of bereaved parents which have men in them as much as women. And there's been a lot more attention for this issue in the global arena. Last Women Deliver conference, there was a specific session on stillbirth, including a bereaved parent, a man who really stood up and did a wonderful job on really kind of helping us understand what it feels like from a male perspective. So, and that's really very opening in this discussion, which is so tough and oftentimes gets labeled as it's the woman's fault, she couldn't carry to term or something like that. So I think there is a real dynamism, new energy into that agenda that my community, our community, wholeheartedly embraces.
Can I add also something to that? You may have noticed my presentation was very much focused on the birth process. I did that deliberately. And I think with all the quality and respectful maternity care, we need to pay more attention to the management of the first and second stage of labor. The global community has done an enormous amount on the third stage of labor to prevent postpartum hemorrhage. That is fantastic work. Still, 50% of women who have no coverage cannot benefit from that. But people who go through labor and delivery attended, those 50% we also need to focus on, and we need to focus on it very well. It has been neglected. I'm afraid to say the first and second stage of labor have been neglected, and we have to pay more attention to that, because most of the stillbirths are intrapartum. And Zanzibar has shown now, with data and the partograph, which of course is my passion, but we leave that aside, it can show that we can reduce stillbirth and birth asphyxia. I just wanted to.
Thank you. That was very nice. Can we go to our second question?
Thank you to all of you for wonderful talks. The question I have is slightly removed from the issue of stillbirth, going back to the issue of contraception. Having worked for 10 years in Pakistan, what we found that about 40% of unintended births in the area where we were working were due to failure of short-term contraceptive methods. And as you mentioned in one of your responses, one of the biggest challenges is side effects of contraceptive methods. And what I am wondering your thoughts are regarding the issue of innovation in contraceptive methods. Really, we have not seen anything which is very different or more than an incremental change in at least the last 15 years in terms of what is available for contraceptive purposes, and what you think are necessary investments which would move this field further along, because we see so much innovation in pharmaceuticals, but just not in contraceptive methods.
Yes, although I'm not a specialist in this area. I agree with you completely. I think we as that the community is not investing enough in this issue. You know, there's some interesting analysis that's been done looking into the idea, how women in particular respond to the idea of male methods, which I think is a major gap. And it's interesting because women will say, well, I'm leery of a male method. I would trust my partner, but I don't trust men in general. So I think that's a challenge that we would have to face in terms of the acceptability of a male method in particular for women. I mean, there is some work being done on developing and testing methods, but I'm honestly not sure where they stand in terms of how soon they would be ready to be rolled out. But you're right, basically we're tweaking things, Uniject, et cetera, the Sayana Press. We're taking methods that have been available and making important, but marginal improvements in them, but we haven't come up with anything really new. And it's a lack of investment. I'm not sure, I think USAID has been investing, the Gates Foundation has been investing. I don't know how much private pharmaceutical companies are investing, but we certainly need more. I don't know if anybody else here knows more about this than I do, actually.
I think that part of this, again, is coming together as men and women around this agenda, because I'm sure that there is leeriness among men as well to have more methods that might impact on them, or to have to take a pill that makes them feel queasy and very irritable for half of the month and stuff like that. If you compare that, sorry, but that's what it's like, And, so I think that and then if you look at who are the heads in the pharmaceutical industry, it's very male dominated still. So to me, in many of the things that we're talking about today, it's a question of coming to a tipping point. It's a kind of a movement, and I think the ones that we're seeing around us at the moment for different topics, Me Too or She Decides have been mentioned, but there are many other ones. I think that is where we can all contribute to, even if it's not specifically related to contraception or specifically, there is a movement. We're getting close to a tipping point where I'm hoping that things can change to be more open and equal in the desires and the needs of all the population, be it men versus women or women versus men, be it countries, at different levels of development. So, for me, the whole set of movements that we're seeing at the moment are actually really, really hopeful. Talking about the stillbirth movement, Butterfly Awards is what they're helping each other with, to recognize how they kind of value what's gone on in their lives, and men are so at the forefront of that. It's really amazing. So I just wanted to put that out there as a very open and bright, I hope, way forward. Any further questions? Anybody would like to raise anything else? Okay, then I think we can round off. And thank you all very much for your contributions. It's been great, and I look forward to your next session.